Hello, everyone. Good afternoon. I'm Dr. Monica Pansari. I'm a surgical oncologist in Fortis Hospital, which is at Banegata Road. Um I mainly deal with women oncology, that is breast and gynec cancers. Um as we all are aware that breast cancers has become one of the most common cancer in not only in Indian women but globally. So we've decided to discuss more about breast cancers today. uh, in general, if I talk about epidemiology, what breast cancers are, how the incidence of breast cancer is, it is said that if you see the global incidence, all in a group of around 8 to 10 women, at least one female patient is one female is going to develop breast cancer in their lifetime, and it also contributes to almost one fourth of, in general, overall female cancers. One fourth of the cancer burden is contributed by breast cancer. So these are few important reasons, few important points why we all should know more and more about breast cancer. And in Fortis Hospital, Banegata Road, I mainly deal with breast and gynec cancers. And there's one more entity which I am more focused upon is something called as peritoneal surface cancers, where in we do a lot of major cytoreduction surgeries and a procedure called HIPEC. So I'm a HIPEC trained specialist as well. So without wasting much time, we'll get started with the discussion on breast cancer. And today's topic, as you all know, is that mastectomy, that is removal of breast, is not mandatory for all the breast cancers. So to reach this topic, we need to know a few basics about breast cancer. As I've told, breast cancer is one of the most common cancer. What are the risk factors for breast cancer? That is what one should know. Breast cancer risk factors, if we divide, they are into whether they are modifiable or non-modifiable. Modifiable means which we can take care in our lifestyle and can modify in our life, day-to-day life, and thereby can reduce the risk of developing breast cancers. Those are the modifiable risk factors, like unhealthy dietary habits, physical inactivity, obesity. These are excessive consumption of alcohol, tobacco. All of this can increase the risk of one developing breast cancer. In breast cancer, when we talk about, there's one very important part is reproductive history, which one should know. Women who have early menarche, that is, they have attained puberty at a very early age, less than 13 years of age, having menopause after the age of 50 to 55 years, not having children, nulliparity, and not feeding their children, that is non-lactating women, this also can increase the risk of when developing breast cancer. So these are few risk factors which we can alter in our lifestyle. Other non-modifiable risk factors, when we talk about advancing age, obviously one cannot change that. Then genetic factors, around 5 to 10% of breast cancers could be genetic, and that is why family history is extremely important when we talk about breast cancer incidence. So these are few risk factors which one should be aware, which can increase the risk of developing breast cancer. And nowadays, when we talk about advances in the breast cancer diagnosis, one should know that there are certain software which are available, which can determine what is your risk of developing breast cancer in your lifetime. So these softwares you can discuss with your oncologist or with your clinicians, which are easily available. You can feed your data, whatever, with all these risk factors, whatever I have enumerated, including the family history. If a person's grandmother or first degree or second degree relative, somebody had breast cancer, you can determine your risk also of developing breast cancer in your lifetime, and thereby you can take the necessary step for early detection. So this is just a little basics about risk factors, about your how to determine one's risk of developing breast cancer. Now, what are the signs and symptoms which one can have, which one should be aware of? So most commonly, patients, they come to us with a lump in the breast, which is the most common symptom one can have when they suspect breast cancer. Other symptoms could be nipple discharge, mainly blood stained. If it is blood stained discharge, one should definitely be very watchful for that. Any change in shape and architecture of the breast, thickening of the skin, lump even in the armpit region could also be a warning sign. So basically, it is said that any unusual change, if one notices in the breast, should be brought to the notice of a physician or your treating gynecologist or oncologist, and should be properly evaluated. Then next comes, what are the screening? How to detect the cancer early? That is what our main topic for today's discussion is. That not all the breast cancer patients should undergo mastectomy. So most important thing here, what one should understand is that how to avoid removal of breast is the main reason why we should know what early diagnosis is and how one can detect the breast cancer at a very very early stage. So for that, we need to understand what screening is. Screening is basically a test which is done in a normal asymptomatic person, that is a female who doesn't have any signs and symptoms of breast cancer, but they are at a little increased risk of developing cancer. We say that women above the age of 40, as I've mentioned in the risk factors, that as we age, there is increased risk of developing cancer. So women above the age of 40 should undergo certain tests that at a periodic interval, and that is basically with the idea of detecting the lump as early as possible. So for breast cancer early diagnosis, what is the screening test recommended? The gold standard is mammography. That is, all women above the age of 40 should undergo annual mammogram. If not possible annually, at least once in 2 years, they should undergo mammogram. The idea of doing frequent mammogram is to detect the lump or any abnormality in the breast much before it becomes symptomatic. So that is why screening is recommended in asymptomatic individuals, those who have no symptoms. So when we do these tests at a periodic interval, it determines or detects the lump when it is very small in size, even much before a clinician or an oncologist can palpate during clinical evaluation. So this is one of the most important gold standard of screening. Second, what we say is that in younger women, what they should do to determine if there is anything abnormal. So for young patients above the age of 20, it is said that they should know what breast self examination is. Breast self examination should be done every month, a week after their periods, when hormonal changes in the breast are least. One should feel their own breast with the flat of your fingers. So once you examine yourself with the flat of your fingers, you can determine if the breast is feeling normal. If it is, there is something abnormal you can feel, you should get it reported and get it checked. And it is said that breast self examination should be done in the lying down position also, because that is when even the small lump or small abnormality can be picked up by you, or in the standing position as well. So both the positions one should examine for breast self examination. This is for younger patients. Also, one important thing one everybody should know is that in younger patients, whenever there's any abnormality detected, we always ask for an ultrasound breast, not a mammogram. Mammogram is always recommended as a screening test in women above the age of 40. So this is what two basic screening guidelines are there, which we all should know. Breast self-examination in younger women. We say that one should be aware of breast. We say that we be breast aware. You should know how your normal breast feels. Only then you can determine how the abnormal, how to pick up the abnormal lesions. And mammography in women above the age of 40, which is mandatory. The idea of doing screening is to pick up the tumor as early as possible. So, what mammogram basically does, as I've explained already, that it picks up the lesion or lump even much before it has become symptomatic. So, as we progress towards now the complete workup for evaluation of breast lump, mammography becomes the mandatory thing to pick up the lesion at a very, very early stage. And if the lesion is picked up in an early stage, that is when we can talk about breast conservation surgery. That is to avoid mastectomy. Before I go to the treatment or surgical part, I should let you all know that once a lump in the breast is diagnosed, and either by mammography or by the clinical evaluation, or by yourself while you were checking your doing breast self examination, you picked up a lump. There has to be a proper evaluation done before we plan the surgical treatment. So, what are those evaluation steps one should undergo? The most important, as I've told, either ultrasound or mammography, followed by a biopsy. There is a myth in the society, and of late, I've been seeing quite a lot of patients coming to me that biopsy can spread the tumor, which is completely a misnomer. This is not what is true. Once a lump is picked up in the ultrasound or mammogram, it has to undergo biopsy to know whether it is a cancerous lump or a non cancerous lump, because in not all the breast lumps are cancerous. There are significant number of lesions or lumps in the breast which can be non-cancerous. So for many non-cancerous lumps you may not need surgery. For example, a small fibroadenoma, a cyst which is in the breast, we may not offer surgery, right? So unless we know whether it is cancerous or non-cancerous, we would not be able to determine what treatment to offer. So, for us, after the mammography, as an oncologist, we should know whether the lump is cancerous or non cancerous. So, for that, biopsy is mandatory. And there is a strong myth in the society, a lot of patients coming to us saying that biopsy will spread the tumor, which is not right, which is completely a misnomer. One should not believe it, because we will not be able to offer the treatment unless we know what the biopsy results are, whether the lump is cancerous or non-cancerous. So once the biopsy and initial mammography is done, after that we offer something called as how we need to know what stage one belongs to. So for that, there are certain tests which we need to do. PET CT scan is one of the imaging which we offer for many of our patients to know what is the stage of the tumor, and depending on the stage, our further treatment is planned. When as we all know that there are a lot of advancements happening in the surgical treatment what we offer these days to our patients, breast conservation surgery has become the standard or norm these days. The most important prerequisite for offering breast conservation surgery is this, that we should try to detect the malignancy in a very early stage. So early stage determination is the prerequisite when we offer them breast conservation surgery. What does that mean? The lesion. So, what are the when can we avoid mastectomy? Any tumor which is confined to one area or one quadrant of the breast, little away from nipple areola, these are the standard indications where we can offer conservation surgery. What breast conservation surgery means is that we are trying to preserve the breast, removing only the lump with a wider margin of normal breast tissue all around, and trying to provide as best cosmetic outcome as possible. What does mastectomy means? Mastectomy means the removal of entire breast. Whenever breast cancer is occupying more than one quadrant of the breast, that is in two areas of the breast, or a large tumor sitting in just behind the nipple areola, or if there are a lot of skin changes or skin involvement, we call it as inflammatory breast cancer. There are these are few indications which are indicators of advanced malignancy where we cannot offer breast conservation surgery, that is breast preservation in breast cancer patients. Rest of the areas where the tumor is smaller in size, confined to one area, there's no multicentricity, that is not, a cancer is not spread to multiple areas in the breast, we can offer them conservation surgery. So, as I've mentioned repeatedly earlier as well, for offering breast preservation surgery, early diagnosis is the prerequisite. We need to have cancer diagnosed and as early stage as possible. So, how do we plan breast conservation surgery? So, as I've mentioned earlier, when we start planning surgery, we have to have an ultrasound or MRI of the breast done in young patients to rule out there is no multicentricity. There's no cancer in other areas of the breast. And then we plan conservation depending on the initial evaluation. When we plan conservation, we remove the lump with a margin of at least around a centimeter of normal breast tissue all around. And we always try to determine intraoperatively during the surgery whether we have removed the tumor completely. We assess the margins. So we always do intraoperative biopsy, the results of which we get within half an hour. We call it as frozen section, which determines that all the margins, there is no cancer at the margins. So that is how we determine that, the tumor which was there, we have removed it in toto. There's nothing which is left behind, and all the margins where we have removed the lump, it is completely negative. So once that lumpectomy is done, or wide local excision of the tumor is done, we always do a procedure along with that, which is oncoplasty or reconstruction. Because there is a defect in the breast now, so we need to fill in that defect. So for that reconstruction, there are different kind of procedures which we offer to provide them best cosmetic outcome. If the tumor is small in size and the volume loss is small, we do something called as local oncoplasty or volume displacement surgery, where we use patient's own breast tissue or breast pillars and mobilize it in a different direction and fill in that defect and provide them best cosmetic outcome using the breast tissue of the patient herself. So this is what we call it as local oncoplasty, where we have just done the volume displacement. We just utilized the volume of the patient's breast tissue and filled in that defect to provide them best cosmetic outcome. But if the tumor size is large, breast volume is small, we need to have a certain different kind of reconstructions which should provide them the good cosmetic outcome, where sometimes we do involve our plastic surgery colleagues, and there are different kinds of flaps wherein we use tissues from different areas of the body. Sometimes we use from the back latissimus dorsi muscle flaps, sometimes local flaps, sometimes free flaps. Different kind of tissue replacement techniques are available, which we discuss with the patient if the volume loss of the tumor size is large. So that is what we call as volume replacement oncoplasty, where we have replaced the volume from different areas of the body and have given them good cosmetic outcome. So because of these reconstructive technique, whether it's local reconstructive, that is utilizing patient's own breast tissue, that is oncoplasty, local oncoplasty, or volume replacement techniques for reconstruction, our indications for offering breast conservation surgery has widened up. Like, even if the tumor is little larger in size, and if it is oncologically, that is cancer parameter wise, if it is safe to offer them conservation surgery, we can offer even in larger tumors, but with the reconstruction technique in place. So because of this reconstruction technique, indications of breast conservation surgeries in breast cancers have increased widely. But the most important prerequisite, what you all should discuss with your oncologist, is that uh, whether it is oncologically safe or not. Because if multicentricity is there, if skin involvement is there, if diffuse skin involvement is there, it may not be safe to offer conservation. So there are only few limited contraindications in cases, in few cases, breast cancer cases, where mastectomy becomes mandatory. In certain patients, for example during pregnancy, whenever we can't offer them radiation therapy, because following breast conservation surgery, radiation is mandatory. So whenever we preserve the breast or we offer breast conservation surgery, radiation is must. That is, breast conservation surgery plus radiation is equal to mastectomy. So there are few patients where we can't offer them radiation. In that case, in those cases, conservation becomes we cannot offer them conservation. For example, a pregnant lady. A pregnant lady, even if we are offering her surgery during safe period during pregnancy, second trimester, we cannot offer her conservation. The most important reason is this: during pregnancy, we can't give them radiation. So there are certain other medical reasons where radiation cannot be given. In those situations, we cannot offer them breast conservation surgery. So these are few common scenarios where breast conservation is contraindicated. And as I've discussed, that these days breast conservation surgery has become the norm, especially in younger patients. And if they are detected early. So early detection becomes a very crucial thing in offering best cosmetic outcome in breast cancer patients. So this is what is mainly about the management of breast cancer. Especially in when is mastectomy mandatory? No, mastectomy is not mandatory. In most of my cancer patients, breast cancer patients, if they're coming to me in a safe, oncologically safe zone, I always offer them breast conservation. Especially young patients, as far as possible, conservation we offer them. Now, second important part of treatment in breast cancer is how do we do with axillary lymph node, right? What do we deal with? How do we deal with axillary lymph node? Because breast cancer, the first step of spread is in the axillary lymph node. So for that also these days we offer them something called a sentinel lymph node biopsy, wherein in again in early stage patients where there is not N0 disease, we call it, as where there in the clinical evaluation we haven't found any cancer spread in lymph nodes, then we offer them a procedure called sentinel lymph node. What does that mean? The standard of care for axillary lymph node has been axillary lymph node dissection, where we try to remove all the axillary lymph nodes, at least 20 lymph nodes from the armpit area where the cancer can spread. And the most important challenge, most common complication, what we used to see is lymphedema. Lymphedema means swelling of the arm of that hand where the axillary lymph nodes have been removed. You would have seen many women coming with one swollen arm post breast cancer treatment. So the most common reason was axillary lymph node dissection. To avoid that complication of lymphedema, these days we have the standard of care, which in our Fortis hospital we do. We have a special instrument for that, sentinel lymph node biopsy, where we inject a dye in the retroareola, that is near the nipple and areola, and that dye travels to the armpit region, that is the axillary region. So we pick up those primary, sentinel means primary draining lymph nodes, which are three or maximum four in number, which mainly drain the breast tissue. So those that dye will be picked up in those primary draining nodes. We remove only those three or four nodes. We send them again for intraoperative biopsy, that is frozen section, and within few minutes we get the results. And if there is no cancer spread in those primary or sentinel node, there is no need to remove the entire group of axillary lymph node. So we avoid axillary lymph node dissection, which thereby reduces the risk of developing lymphedema or swelling of the arm. So the standard of care for even axillary lymph node dissection these days in early stage breast cancer has become sentinel lymph node biopsy. That is the injecting the dye, picking up only the few nodes, and if there is no cancer spread in those nodes, there is no need to offer complete axillary lymph node dissection. Again, the prerequisite in this for offering sentinel lymph node biopsy or SLNB is early diagnosis. So, for offering the best treatment, even for axillary nodes, is prerequisite is early detection. So if we somehow we can pick up and make our people, general public, aware how to detect the breast cancer early, what are the signs and symptoms, what the screening protocols are, what imaging one should undergo, and not to ignore their symptoms. If we can pick up the disease early, the standard of care becomes breast conservation surgery with local with reconstruction, either oncoplasty or volume replacement of flaps technique with sentinel lymph node biopsy. So we can avoid mastectomy, we can avoid axillary lymph node dissection, and thereby the complications associated with that. Like for axillary lymph node dissection, we can avoid lymphedema. Obviously, by losing breast, the cosmetic deformity, along with that psychological impact on a female's body image, can all be taken care if we detect the cancer at a very early stage. And early detection, we all should be aware how to do that. So these are two important aspects, that breast conservation surgery and sentinel lymph node biopsy, when to do it, and a little bit I have explained then who should be undergoing all of that. Another very important think a question which people ask and not very comfortable with is that why do we give chemotherapy first? In many of our breast cancer patients, I have seen that patients are not very comfortable with idea of giving chemotherapy before surgery. So this also I would want to share a few points on this topic, which we call it as neoadjuvant chemotherapy. I hope you all would have understood about what are the indications of breast conservation surgery, and that the mastectomy is not mandatory for all breast cancer patients. And if we can determine the cancer in a very early stage, breast conservation is the norm, is the standard of care. This, as I said, there is another thing which is called as, we call it as neoadjuvant chemotherapy, which has become pretty common these days in breast cancer management. So one should not fear if the chemotherapy has been asked to be given before surgery. These days, breast cancers have become, as we all know, very common. There is a lot of information about breast cancer treatment available, and we all, because breast cancer patients, they usually do very well long term. So we have a lot of information about their molecular types. What is the tumor type, molecular subtype of breast cancer, and how do they do in long term? So depending on that, there are certain cancer where we try to give them a better long term outcome because they are very aggressive, and offer them chemotherapy upfront followed by surgery. So when chemotherapy is given before surgery, we call it as neoadjuvant chemotherapy. It is given in various indications are there. If the breast cancer is diagnosed in a very in a little advanced stage, we call it as locally advanced breast cancer, where tumor has, in our initial evaluation, we found that tumor has gone to axillary lymph nodes. So in those situations, we'll be giving them chemotherapy first. Second indication is when the cancer which is diagnosed as molecular type of triple negative breast cancer, where in when we do molecular subtyping in the biopsy, all the markers, that is estrogen, progesterone, and HER2 receptors, all three markers are negative. We call it as triple negative breast cancer. And if it is something called as HER2 marker positive, so if it is HER2 positive triple negative breast cancer, even if it is early stage, we would offer them chemotherapy before surgery. And if it is a locally advanced breast cancer, definitely chemotherapy has to be given first, followed by surgery. So what chemotherapy does if we give before surgery, it has got a lot of benefits when we treat a breast cancer patients. First important thing is, even in the PET scan, if there is no systemic spread, there's no spread to our organs, despite that there can be some microscopic cells wandering around. So when you give chemotherapy upfront, it takes care of all those microscopic cells. Along with that, it shrinks the main tumor. So if the tumor, which is 6-7 centimeter in size before starting chemo, it will shrink, may become 1 centimeter. In few patients, it completely disappears also. So it does give benefit locally because it makes the surgery much simpler. So those larger tumors where we were not able to offer them breast conservation surgery, post neoadjuvant chemotherapy, the tumor shrinks and we can offer them breast conservation surgery. And also, it takes care of systemic microscopic dissemination of cancer. That is, in the blood circulation, whatever cancer cells are there, it will attack those cancer cells if we give chemotherapy before surgery. So these are two main advantages of giving chemotherapy in locally advanced breast cancer prior to surgery. It makes our it does increase the indications of breast conservation surgery. So if neoadjuvant chemotherapy is offered to a patient, they should accept it because there are various reasons. Your oncologist would have thought pros and cons of it, and that is the reason why they are offering you chemotherapy before surgery. So for today's topic also, even in locally advanced breast cancers, we can offer them conservation, and mastectomy is not even mandatory even in locally advanced breast cancers also. If we give them chemotherapy and if the tumor shrinks and if it is doable, we do offer conservation for those patients as well. So at the end of the topic, I would say that, breast conservation surgery these days have become the norm. Mastectomy is not mandatory, but Post breast conservation surgery radiation is mandatory, but for all of this to happen, it is extremely important that we spread awareness that what are the signs and symptoms, what are the risk factors, and what are the screening modalities we have for early detection of breast cancer. Early detection is the key. Early detection saves not only lives, it saves lives, it makes a cancer treatment quite easy. It also saves breast. That is, we don't have to do mastectomy. We can offer breast conservation surgery if the cancer is detected early. So, this is what is my take home message. Early detection saves lives, saves breast, and makes a cancer treatment quite easy if it is detected very early. There are few patients where we can avoid chemos as well. Thank you so much. We can move on to questions now. If somebody has questions, I can take it. First question is what causes breast cancer? So, in the beginning, I have enumerated few risk factors. Breast cancer is basically multifactorial. Multiple factors play a role in causing it. Lifestyle changes, unhealthy dietary habits, in physical inactivity, obesity, not having children, non-lactating women. 5 to 10% of cancers could be genetic as well. So these are all the factors which can contribute to one having breast cancer. Breast cancer, this is a very good question. Will my breast cancer treatment affect my ability to have a baby? Yes, this when we start chemotherapy can impact ovarian function. So, if a young lady who's undergoing breast cancer treatment, and if they are planning to have family later on, you are supposed to discuss in detail with your oncologist because there are multiple treat options which are available. Many times for young women who are married, we ask them to undergo embryo preservation or oocyte preservation and meet an infertility expert because it can chemotherapy impact the ovarian function. So this is a very valid question and it has to have an open discussion before starting chemotherapy. Sometimes during chemotherapy, we do give ovarian suppression injections to suppress the ovarian function during chemotherapy so that the effect of chemo on ovarian function is less. What is inflammatory breast cancer? So it is a type of cancer which is considered to be very aggressive, wherein there's extensive skin involvement, large tumor, uh, basically a kind of very aggressive tumor, I would say. Yes, men can also get breast cancer. Again, a very important question. Though the risk of cancer in men is quite less as compared to women, but yes, men also get breast cancer, and mostly if there is a history of male breast cancer in the family, it is high chances of it being genetically associated. So, if a male has a breast cancer, one should definitely undergo hereditary genetic mutation testing. That is BRCA1 and BRCA2 should be done. But yes, males they do get, though rare. Yes. When should I begin? I think during my discussion I have answered already. One should, for an average risk female, they should start their screening at the age of 40. But if there is significant family history or history of genetic mutation, their screening starts quite early. It is said that 10 years prior to the diagnosed patient in the family. So, for example, in the family, first degree relative had breast cancer at the age of 30. Other family members should start, especially first degree family members, should start screening at the age of 20, 10 years prior to the diagnosed patient. For average risk females, at the age of 40, they should undergo screening. They should start screening. What type of doctor should I see if I think I have a breast cancer? A very valid question because most of our breast cancer patients with breast lump they usually go to either physician or gynecologist, and that's when they get referred to us. Many a times we have seen they have undergone lumpectomy without proper evaluation, which shouldn't happen. So, if there is any suspicion of breast cancer, you should meet a surgical oncologist or an oncologist or a breast oncologist. These are the two doctors who will detect you and evaluate you properly for your proper treatment. What does breast cancer feel like? See, as I said, the most common symptom of breast cancer is a lump in the breast. So, that is the most common presentation. If any lump or abnormality is felt in the breast, could be a sign of breast cancer. Other symptoms could be, other than lump, nipple retraction, blood stain discharge from the nipple, change in the shape and architecture of the breast, thickening of the skin. All of these things could be a rare symptom of breast cancer. Does breast cancer hurt? Very important question again. Breast cancers to begin with is usually painless. So that is one very important reason what our patients they come to us saying that we did not come to the doctor because it was painless. So all the cancerous, mostly breast cancer lumps are painless to start with. They become painful only when it becomes a little larger in size, infiltrating skin or surrounding structures. Otherwise, they are painless to start with. It's always a painless lump. What treatment options are typically available? I have mentioned for breast cancer, there are three modalities of treatment which we offer: surgery, chemotherapy, and radiation. It all depends on your evaluation, what we do, what treatment we are going to offer. But when it comes to surgery, there are two types of surgical options which we have discussed in detail today: breast conservation surgery or mastectomy. So, all of that will be decided by your oncologist, which option is feasible for you. How can I manage the side effects of breast cancer treatment? See, it's a very long question, but yes, mostly see when it comes to surgery, there are no major side effects of surgery because it's a surface surgery, very well tolerated. We usually mobilize and our patients are back to normal activity within a day or two. The only thing post surgery they're supposed to manage is the drain tubes, which usually explain how to manage it at home. Now, when it comes to chemotherapy, there are certain side effects which are usually seen. Hair fall, which is reversible as soon as you stop your chemo, hair growth is going to restart. Then some amount of weakness, tiredness, nausea. So for that, we give little bit of dietary advice which one can follow. For nausea, vomiting, constipation, alteration of bowel habits, you can discuss with the medical oncologist, which they will tell you what treatment to take. Some medications will be given to you. Other than that, there are no major side effects as such because mostly it is manageable. Post radiation, there will be some kind of skin changes which you will notice at the end of the treatment. Hyperpigmentation, that is blackish discoloration of the skin, can happen, which again is reversible. Within few days or weeks, it does disappears. So mostly it is symptom management is personal. Few patients will have more symptoms, so they will be guided accordingly. Few will not have any symptoms, so they'll be guided accordingly. What if I don't want to have breast cancer treatment? Obviously, see, cancer is not going to stop growing. If one is not going to have breast cancer treatment, it is going to grow. Locally, there can be problems within the breast and outside the breast. So once it starts growing in the breast, it can form wound, or we call it ulceration, which can have bleeding, pus discharge, blood discharge, and can become infected, foul smelling, which will be uncomfortable not only for you but for your family members also once it continues to grow, because cancer doesn't stop growing. It might be an aggressive cancer, it might grow rapidly. In slow growing cancer, it might grow slowly. So it is going to grow. It can cause problems in the breast and outside the breast because it can spread to your organs, like it can spread to liver, lungs, bones, brain. So it can give those side effects as well. If it goes to lungs, obviously breathing difficulty and all of those complications can happen. So systemically different side effects and complications can happen. So obviously we wouldn't recommend that not to undergo treatment. What are the different options for breast cancer surgery? I think we've discussed in detail about the options for breast cancer surgery. Two main things options are mastectomy or breast conservation surgery, and axillary treatment, either sentinel lymph node biopsy or axillary lymph node dissection, depending on the stage. So we've discussed in detail what breast conservation surgery is, what total mastectomy is, and how to treat axilla, either sentinel lymph node biopsy or axillary lymph node dissection. Which surgical option do you recommend and why? Okay, so I have discussed in detail in the webinar that two different options are there. Depending on the stage and clinical evaluation, we decide which treatment to offer, whether conservation or mastectomy. So we prefer offering conservation surgery if it is oncologically safe for the patient. So any tumor which can be resected with a normal margin of around 1 centimeter with a negative margin, and I can offer them cosmetically good outcome, I would recommend to offer breast conservation surgery. And if post-op radiation is possible, if there is any contraindication for radiation, if the tumor has got multicentricity, that is involving multiple quadrants, if it is an inflammatory breast cancer, these are few contraindications where we cannot offer them conservation. So yeah, these are the two treatment options which we will assess after evaluation and then decide which surgery to offer. What are the potential side effects of breast cancer surgery? So there are no potential side effects as such for breast cancer surgery. I would say complications of surgery. So for any surgery, as we see for breast cancer surgery, if we are doing mastectomy, immediate risk factors could be of side effect, like complication is bleeding, some amount of obviously cosmetically one has lost the breast, so mastectomy is associated with that. Some patients can have seroma, that is water collection in the armpit region, if the axillary lymph node dissection has been done. So seroma formation, wound infection, bleeding, these are few complications for following mastectomy. But when we offer breast conservation surgery, that has got few complications. Bleeding, seroma happens here as well. Wound infection can happen. Rarely in my clinical practice, I don't see these complications happening in any of my patients. But yes, these are the potential complications which one can have. Cosmetically, deformity, a little bit of volume loss, volume disparity, these are the complications which breast conservation surgery can have many times, because patients, they don't opt for reconstruction. So, if it is for breast cancer surgery treatment, usually hospitalization is needed for 2 to 3 days. Because it's a surface surgery, we admit them a day prior in the night or many times early morning also. And young patients, usually we discharge them next day itself, because mostly they are quite comfortable next day discharge. So, maximum 2 to 3 days. Okay, I guess we can end the session now. Thank you so much for patient listening, and then a lot of questions asked, very relevant and specific questions. So I would end my discussion with the fact that we can offer breast conservation surgery these days for many of our breast cancer patients, and mastectomy is not the norm. The only prerequisite is for offering conservation or preserving breast is early detection. So early detection by different screening modalities, which I have discussed in my session, leads to reduced mortality, that is reduced cancer death rate. It can reduce the it can make your cancer treatment quite simple if it is detected very early stage, can avoid chemotherapy in few patients. And third most important uh, reason for early detection or benefit of early detection is we can preserve breast. So we can not only reduce the mortality, we can reduce the number of breast being lost, or we can offer most of a patient breast conservation surgery if we can detect the cancer early. So early detection is the key for all the breast cancer treatment for best outcome. Thank you, everybody.